Hello guys, hope you're all okay. You're all enjoying your life and welcome back to Dr. Arshad Nadeem Awan Ultrasound teaching videos. Today my topic of discussion is quite important and every now and then you will come across with this term, that is PID. PID is abbreviated as pelvic inflammatory disease and which is very common and increasing in frequency. So far this pelvic inflammatory disease is concerned, it is caused by certain abnormalities. Like, first of all, it is considered to be a sexual transmitted disease caused by gonorrhea or chlamydia. So these are the two main reasons to cause the pelvic inflammatory disease. But prior disruption to endometrial tissues or due to any other abnormalities like post or preoperative or any tubal interventions, it may lead to pelvic inflammatory disease. So now first important thing is when we will apply this term as a PID, and how many organ and structure will be involved in PID. So mind you that inflammation of the endometrium, inflammation of the fallopian tube, inflammation of the pelvic peritoneum and adjacent structure if involved, that would be considered as a pelvic inflammatory disease. Actually it's a complex of diseases, so all these area if involved and if inflamed, that would be considered as pelvic inflammatory disease. The long-term sequels of the pelvic inflammatory disease includes infertility, pelvic pain, and there is great chance of getting tubal or ectopic pregnancy. So far the ultrasonic importance are concerned, so TDS and Doppler is the main important diagnostic tool to look for the pelvic inflammatory disease. On the ultrasonic imaging, sometimes physically you can palpate the pelvic mass, and on the ultrasound imaging, if there is vascularity within the wall of the fallopian tube, you appreciate that is the highly, that rather I would say is a hallmark of the PID. On the PID, the inflammation of the fallopian tube is very specific, along with if there is any vascularity. So this is very conspicuous sign, and it indicates that it is PID. PID is usually happens soon after inserting the IUCD. There is again a chance in early days of the insertion of the IUCD. So one may get the pelvic inflammatory disease. That's why during the IUCD it is important to follow up after 2 or 3 weeks to look whether it is normally placed or if there is any infections within the endometrium. And if there is infection, so it will definitely be PID, because the PID include inflammation of the endometrium. So that may be because of insertion of the IUCD. Some infection may ascend upward up to the endometrium during the process, and it may lead to PID. As the disease progressed, endometrial wall get thickened, endometrial fold get thickened, and intraluminal blockage may occur. And it may be seen as a simple fluid within the lumen, or maybe low-level internal mucus, or maybe purulent fluid within that. So these are some findings if the disease progress and progresses in the progressive stage of the pelvic inflammatory disease. On the transabdominal scan, you may appreciate as a complex adnexal mass, and it would be indistinguishable from all these complex adnexal cystic lesion, although they will be in dilated fallopian tube. But as I mentioned that on transabdominal scan, it would be indistinguishable. As far as its non-specific features are concerned, non-specific features are fluid within the endometrial cavity, or fluid in the cul-de-sac, or thickening of the endometrium. So if there is thickened endometrium and fluid within the endometrium, it would be rather more endometriitis. But again, if inflammation of the endometrium is there, it would be also considered as PID. So these are all the non-specific signs, so you may put on your report as well as a PID. There are certain important signs which educate that this would be a PID, that is considered called as a cogwheel sign. When the fallopian tube get thickened, when the internal folds get thickened up to 5 millimeter, that would be called as a cogwheel sign. The second sign is called as beads on the string. This is, it will appear as a beading, so you will see on the images later. The third sign is incomplete septa. So there will be internal incomplete septa. So normally in loculated cystic lesion, you will see there will be a complete septation from one wall to another wall. But in case of hydro or pyosalpinx, you will see that these septa will be incomplete. This is a very important feature. Whenever you come across any tubular lesion or a cystic lesion having incomplete septa, you must consider this would be a inflammatory disease, this would be a hydro or pyosalpinx, or this will be a due to pelvic inflammatory disease. So all these points has been already discussed. I'm gonna show you some of the slide and images. On these slides I will again narrate all these findings, and it will be easy for you to pick on the ultrasound imaging and pin down all these information on the ultrasound report to produce a very quality report. So let's start watching these images. This is transvaginal image. On this transvaginal image, you can appreciate small hypoequic tubular structure, which is fallopian tube. This fallopian tube is not significantly enlarged, although it is enlarged to some extent, because if it is visible, it means it's enlarged. We will call it as a mildly enlarged fallopian tube. In the view, you can appreciate ovary as well. Towards the right side, you can appreciate the uterus. However, there is no fluid surrounding the fallopian tube, surrounding the uterus and surrounding the ovary. Rest of other features are quite normal, but mildly dilated fallopian tube is visible in this image. The one thing that is required here to look for the Doppler and the vascularity. If it is surrounded by vascularity, or if the wall of the fallopian tube is vascular, and if there is any other vascularity in the surrounding area, this would be picked and would be labeled as a pelvic inflammatory disease. However, this would be a mild degree of pelvic inflammatory disease. That's why this image is shown to you, that even mild degree fallopian tube would lead to pelvic inflammatory disease. This is the image of the same patient which you have seen previously. This is again the same mildly dilated fallopian tube, but the one important point is worth noting here: the surrounding vascularity and the surrounding area hypervascularity is visible, which shows that some inflammatory changes is going around the fallopian tube, around the ovary, in the parametrial region. So this vascularity is very important to pick the pelvic inflammatory disease point. On the ultrasound imaging, if there is dilated fallopian tube, if there is thickened fallopian tube wall, if there is vascularity around the fallopian tube, if there is hypervascularity around the parametrial region, or if there is vascularity around the ovarian area, this would be considered as pelvic inflammatory disease. It should be picked on the ultrasound imaging. So you have to write that the ovarian, you must give the ovary size. Also mention that the fallopian tube is mildly dilated and the surrounding structure shows highly vascularity. So keeping in view the increased vascularity and mildly dilated fallopian tube, the findings are suggestive of pelvic inflammatory disease. So correlation with other inflammatory marker is recommended, and also further investigation is advised to rule out the real cause. This is a progressive stage of PID. On this transvaginal scan, you can appreciate tubo-ovarian complex mass. This is tubo-ovarian complex mass. However, in this image, separately fallopian tube and ovaries can still be identifiable. These are not adhere with each other. So although it would be considered as tubo-ovarian complex mass because these both are combined together, but still the both structures can be separately identifiable. So this is slightly, I would say, moderate degree of the pelvic inflammatory disease, because fallopian tube is dilated and ovary is also enlarged. As a result, they, because of adherence, because of adhesion, they both are united to present as a complex mass. What you need to do is here, you have to mention that in the view the right ovary and the right fallopian tube is inflamed, enlarged in size, and they are adhere with each other to presenting as a complex mass. So this would be considered as tubo-ovarian complex mass. What important another point should be that you should put Doppler signal on it and look for the vascularity within the mass area, within the ovary, in the wall of the fallopian tube, in the surrounding area. If there is vascularity, so this will add in the information, and this would be a confirmed diagnosis that this tubo-ovarian mass is suggestive of pelvic inflammatory disease. This is a progressive form of pelvic inflammatory disease, and on this transvaginal image you can appreciate tubo-ovarian abscess. This is the conclusion. Now you have to look for the features, what the features are available. So there is cystic vascular mass is visible, so you can appreciate vascularity around this cystic area. There is thick septations within that, so thick septa with again vascularity is still visible here. So this is tubo-ovarian abscess, a complex structure, large mass having a cystic components, thick septations, vascularity. So this is a feature of tubo-ovarian abscess. Tubo-ovarian abscess is a progressive stage of pelvic inflammatory disease. It will come up in this fashion, and on the ultrasound imaging what you would be able to appreciate, there will be enlarged ovary, there would be a cystic thick exudative collection either around it or within it, with thick septations with increased vascularity. So you have to mention on the report that on transvaginal scan complex predominantly cystic lesion measuring blah blah blah, whatever the measurement is, having thick septations, cystic spaces, irregular in shape, measuring that much, give the thickness of the septa as well. It would be highly appreciable if you give the thickness of the septa. It's really very indicative, and it's an important parameter for picking the certain abnormalities. So mention that thing, and in whether it is in the right or left, mention the area as well, and in the conclusion mention that the features are suggestive of tubo-ovarian abscess, is a feature progressive PID disease. Further workup is recommended to rule out the exact cause and nature of cause. On the ultrasound imaging, particularly on transvaginal scan, there are specific signs, specific features for the ovarian abnormalities and for the dilatations of the fallopian tube, and to pick the pelvic inflammatory disease. So these signs are including, the one is incomplete septa sign. Incomplete septa is, these are the septa within the fallopian tube and it remains incomplete. If it is complete, so it would no longer be fallopian tube. So this is what the important particular and specific sign which is called as incomplete septa, to showing that this is intraluminal septa, this is fallopian tube septa. So here on this image, this particular septa has been shown. This is a long and tubular structure which is likely fluid filled fallopian tube, distended fluid filled fallopian tube with incomplete septa. So this is a particular sign which is indicating that it is pelvic inflammatory disease, and on this image it's clearly visible that you would appreciate a tubular structure, anechoic structure, it means there is fluid within this structure, and in between you can appreciate septa. So in different views you can appreciate either single septa or multiple septa, it depends upon the view you are looking for. So this is an example of incomplete septa, and this is pelvic inflammatory disease. This is another transvaginal scan, and it is giving you very complete and full information of the pelvic inflammatory disease. Here you can appreciate that On the top, cervix is clearly visible. Underneath the cervix, there is a fluid collection but having an incomplete septa. So this is an example of incomplete septa. Look towards the right side. On the right side, you can appreciate another sign which is called as beads on the string. So these small follicles, it is indicating beads form, and this is actually in the right ovary, and these are all inflamed because of the inflammation of the ovary. These small prominence of the follicles can be seen as beads on the string. So this is the another sign. So these two signs you can appreciate on this image. The one is incomplete septa adjacent to the ovary, and there is enlarged fallopian. Actually, this what this incomplete septa in this anechoic structure is. This is dilated fallopian tube. So in this fashion, you can appreciate well defined dilated enlarged fallopian tube filled with water, filled with serous fluid, filled with some other exudative material. Beside this, septa would also be visible, and this septa would be incomplete. So incomplete septa with beads on string sign is clearly visible on this image, and this is a progressive stage of the pelvic inflammatory disease which can be easily picked on the transvaginal scan. However, transabdominal scan will not be able to pick all these minor and subtle information. Here, this is another case of progressive pelvic inflammatory disease. This is transvaginal scan and different views has been shown. On the topmost, you can appreciate this is dilated fallopian tube and fluid filled with serous fluid. There is no low level internal echo, so it means it's simple serous fluid, and the fallopian tube is dilated. Beside this, the second point is there is incomplete septa which is clearly visible, indicating that this is enlarged fallopian tube. Comes to the next, in the lower images, you can appreciate beads in the string that has been shown in the cross section. This is actually fallopian tube, and in the fallopian tube you will appreciate small beaded formation which is called as beads on a string. So this is another important sign, irregularity and mucosal irregularity and nodularity of the ovarian of the fallopian tube wall. So whenever internal mucosa of the fallopian tube gets beaded and showing small focal dilatation, it will appear as a beads on the string. So on this image, this is also clearly visible. So you have seen three signs. These are dilated fallopian tube, incomplete septa, string on beads on string sign, and when there are multiple enlarged incomplete septa, this will give rise to appearance of the cogwheel sign. So these are signs which indicate that this is a progressive stage of pelvic inflammatory disease. So specific features for the pelvic inflammatory disease has already been discussed. Now we are coming to the point where some non-specific features may also lead to pelvic inflammatory disease on the basis of the ultrasonography. So this is again a transvaginal scan, and on this transvaginal scan you can appreciate uterus is visible, and within the uterus it is quite clear that there is distended endometrial cavity and fluid filled endometrial cavity is there. So if you come across with fluid filled endometrial cavity and there is no other information available like fallopian tube is normal or ovaries are normal and there is no other features as well, and there is no increased vascularity in the parametrial region, and only the one point that is fluid filled cavity, endometrial cavity is visible, so it is likely that it would be a endometriitis. Endometriitis is a condition when there is inflammation, and because of the inflammation exudations occur, and this may give rise to fluid collection. So endometriitis is one of the major cause for the pelvic inflammatory disease, as pelvic inflammatory disease is defined as endometriitis, inflammation of the fallopian tube, salpingitis and parametriitis and ophoritis. So all these features combine to make the pelvic inflammatory disease. But if you did find only one of the feature, like in that case there is endometritis, fluid filled cavity, so still you will be able to label pelvic inflammatory disease. However, the cause is specific, that is endometritis and fluid in the endometrial cavity, but in general the term which will be applicable here would be a pelvic inflammatory disease. So it is good to mention endometritis with fluid filled cavity suggestive of pelvic inflammatory disease. This is another slide, transvaginal scan, and on this transvaginal scan uterus is clearly visible. Within the uterine cavity again you can appreciate small amount of fluid. It would be also considered as streaks of fluid. So it is a mild degree of pelvic inflammatory disease. It's a mild stage of endometritis. However, this round shape may be mimicking as a pseudo gestational sac. You have to be very careful while you are reporting. Take the patient history, also evaluate whether she has done a pregnancy test, whether pregnancy test is positive or negative, or beta HCG is positive or negative. These are all the information you need to take from the patient. Second, ask for the last menstrual period. Also look for whether patient is in a premenstrual condition or not, or during the menstruation, because if in case of menstruation, if there is small fluid within the endometrial cavity, this would be likely due to the menstrual phase. So if there is menstrual phase, so there is likely possibility there will be small fluid in there. So instead of jumping to the disease process, always look for the physiological process. If there is physiological process, so that's fair enough, mention on the report small fluid within the endometrial cavity, most likely be due to physiological process because the patient is in menstrual phase. But if there is no menstrual phase and this is small fluid still within the uterine cavity, so this would be considered as PID. So the best methodology is you ask the patient for the follow-up scan within 4 to 6 weeks, and within 4 to 6 weeks the patient will return to you. If this fluid is still there and it's not reabsorbed, it means that the patient need medication and patient need proper management. So this small indication will help you to go further and to investigate properly and identify the patient or classify the patient as a mild degree pelvic inflammatory disease, and follow-up should be advised. After explaining the fluid within the endometrial cavity, mild and moderate, and also discussing its physiological and pathological processes, the next is fluid in the cul-de-sac. You may call it as a pouch of Douglas or may call it as a cul-de-sac, whatever you please, you can mention that. But in that case you can see mild to moderate degree fluid in the cul-de-sac. Again, you will have to look for both physiological and pathological processes. During the menstruation and early menstruation and pre-menstruation phase, there may likely be small fluid within the pouch of Douglas and cul-de-sac. This would be then physiological. In case of any rupture of the cyst, previously cyst, if this fluid accumulates within the cul-de-sac, so this will also be looked whether this is because of the rupture or this is truly pelvic inflammatory disease. So these two information should have been should be taken from the patient and previous record. If these both are excluded and there is nothing like physiological and pathological, then the third point is you may consider that as a pelvic inflammatory disease. In this particular case, as the fluid is moderate in amount, however there is no internal echoes, there is no low level echoes, there is no internal other septations or any mucinous products there. So this is a clear exudative or transudative fluid. Still it would be considered as pelvic inflammatory disease, mild to moderate category. So in that case, always appreciate and look for the fallopian tube or the ovaries and the uterine cavity. If there is nothing there and only the only feature is pelvic inflammatory disease, this may still be labeled as pelvic inflammatory disease because of the fluid in the pouch of Douglas and in cul-de-sac. So this is the case of pelvic inflammatory disease, and it is although it is a non-specific sign, but by taking the patient history, by looking the previous investigation and the medical record, you can still consider it as a pelvic inflammatory disease. This is another complicated slide, rather I would say, because on first instance it will look like a soft tissue, but actually this is a pouch of Douglas, and in pouch of Douglas there is complex fluid is accumulated. So this is for sure pelvic inflammatory disease, because no fluid can be contaminated with infective materials if it is not pathological. So this is actually pathological process. However, uterus is clear. Within the uterus, endometrial cavity is okay. So it seems like the patient is in the proliferative phase, and in proliferative phase there is no menstrual period, no menstrual cycle, because she has already passed menstrual cycle and she is in proliferative phase. And with this phase, if you can see this complex structure with the low level echos and sometime mimicking as a soft tissue, and this is fluid, this is complex fluid, I would say purulent fluid with thick exudative material, and this is in the cul-de-sac. So this is a progressive form of pelvic inflammatory disease. So what you need to do is you have to look for the both ovaries, whether both ovaries are okay, are enlarged, or there is any sign or features of ophoritis. Then, because there is a complex fluid, look for the fallopian tube, whether fallopian tube is dilated or not, whether there is fluid within that or not, or there is any other features of ophoritis on the Doppler imaging. So you have to exclude the fallopian tube, you have to exclude the ophoritis changes. If these two features are not there, endometritis feature is in front of you, there is no endometritis, so which is already excluded. So after looking for all these four parameters, if there is nothing and it's only complex fluid collection within the pouch of Douglas, and this is quite complex collection, it may leads to abscess formation even, so that would be considered as progressive pelvic inflammatory disease. So you must mention this on the report, that there is likely chances of developing of abscesses, pelvic abscess. The post therapy scan is recommended within 4 to 6 weeks. So patient would be put on antibiotic and anti-inflammatory. After that, you have to scan the patient. If it is responsive to the medication, fair enough. If not, so this would be definitely a chronic complicated pelvic inflammatory disease would need further intervention. So it should be mentioned on the report properly. This is another transvaginal scan, and on this transvaginal scan you can appreciate well-defined uterus, and this well-defined uterus showing thickened endometrium. So there are again possibility this may be either premenstrual. So if it is premenstrual, so you can appreciate small fluid within the cul-de-sac. So this would be physiological, because in premenstrual and menstrual period there is likely chance of having a small fluid in the cul-de-sac. The second thing is, if it is pathologically enlarged endometrium, maybe endometrial polyp or endometrial hyperplasia, if there is inflammation, so this may be endometritis. So then this would be a pathological case of the pelvic inflammatory disease, having two signs available. The one is endometritis and the second is small fluid within the pouch of Douglas. So having said that, we have already discussed the significant, or you can say a very specific sign of the pelvic inflammatory disease, ranging from the incomplete septa and cogwheel sign, and also beats on the string, which you have already seen slides. And also we discussed about how this fallopian tube wall will get dilated and how it will appear as thickened bead signs. We have also discussed about the ophoritis. All these features has already been discussed, and I am sure this was a quite logical information for you to understand and to put in practice. Whatever you see on the ultrasound imaging, always put in black and white and on your report, so that your report should have all the conclusion, all the description, and the physician or surgeon or gynecologist can understand what you want to say. If there is any complication process, like there is abscess formation or development of abscess or chances of development of abscess, must mention on the report so that it should be properly followed up. If you think that this condition would be resolved by taking antibiotic or anti-inflammatory medicine, must mention on the report and ask the patient for the follow-up imaging. Yes, friend, this was all about the pelvic inflammatory disease or PID. I have explained everything at length. I've explained why it is happens, why it happens, and what are the main organs involved in, and where you are going to label this PID. What are the specific sign and what are the non-specific sign. What are the long sequels like infertility or pelvic pain, maybe ectopic pregnancy, maybe the sequel of pelvic inflammatory disease. So all these points has already been discussed on this video, and images has already been shown. So hopefully this would be a very informative video for you. So again, I would say here that please keep watching my video, keep sharing my video, and if in case of any doubt or any question, just drop me a text and I will get back to you. So with other new informative video, we'll see each other. Till then, take great care of yourself. See you then. Bye bye.